unmuting. We'll have to make us the two of us the host. Yeah. Hello. Can you hear me?
Hello. Hi, doctor.
Hi. Can you hear me?
So, doctor, I can see. Okay, doctor, I would like to know that. Okay, I'm making the other doctors, Dr. Anil Bhatia guest.
Hello. Yeah.
Yeah. So make it as a host.
Yes, Dr. Anil Bhatia, he'll also be the host. We're just waiting for others to join.
Hi, doctor.
Hi.
Yes. So, doctor, I can see. Okay, doctor, I would like to know that. Okay, I'm making the other doctors, Dr. Anil Bhatia guest.
Hello. Yeah.
Yeah. So make it as a host.
Yes, Dr. Anil Bhatia, he'll also be the host. We're just waiting for others to join.
Hi, doctor.
Hi. Yes.
So, doctor, I can see.
Nancy. Nancy, am I on?
Yes, doctor. It's audible, doctor.
Yeah, but there's a delay in the voice. Yeah, there's a few seconds delay, Nancy.
Yes, doctor. Yes, it's audible, doctor. Tell me, doctor.
Okay, you can hear me now, right?
Yes, it's clear.
Yeah, got it. Because there was reflection and there was the. Nancy, am I on?
Yes, I can hear you, doctor. It's audible, doctor.
Yeah, why is the delay in the voice? Yeah, there's a few seconds delay,
Yes, we'll close the room. Just off it. Now it's clear, doctor?
Yeah, better.
Yeah, sure. So, is everyone the host? Just check on Tarun.
Bharat.
Yes.
Anil Bhatia. Yeah. So,
But tell me, doctor.
We'll be following the sequence as you.
Yes.
Earlier.
Absolutely.
Just that, although my presentation is something like 54 slides.
Okay.
But it is all, as how I present. I present only pictorially. So it will go fast.
Yeah.
I'll finish in 10 minutes, no problems.
No, not a problem. 10 to 15 minutes should not be an issue. Oh, yes.
So we're just waiting for Piyush because Piyush is
okay.
I've got 2 surgeries today.
Okay.
Brachial Plexus and a zygoma.
Yeah.
He should have finished. He should be joining now.
He's on. Yeah.
He's here.
I just finished my brachial plexus, but the zygoma is still remaining. I have asked the anesthetist to wait for some time. So I may leave little early.
Okay. Fine.
Yeah.
Welcome. Yeah.
Okay.
So Nancy is our coordinator from the GHA, the Global Health Academy. Throughout the
anyone else
webinar.
We have to make it as a co-host?
Yes, Dr. Srikanth is coming. Dr. Piyush, you can make him as co-host. Yes. Dr. Bhatia. And that's good enough.
We can't find the Srikanth.
I think he's yet to come in. Yeah, he also was in a surgery. He's yet to come in. Okay. So how many participants have joined, Nancy? Can you hear me?
Yes, doctor, I can hear you.
How many participants have joined so far?
No, they will be joining by 5 p.m.
Yeah, I know.
Yeah, so till now only 5 participants have been joined. So we are waiting.
Okay. Have you sent the link?
Yes, I believe Dr. Purushottam doctor will be joining. So I have called him a missed call.
Okay.
Waiting for him.
Sure.
meanwhile, Bharat,
Yeah,
the format for the discussion on 29th,
28th.
28th
Yes.
of October.
Yeah.
See, we are having a half-day session
Yes.
in the afternoon, right?
Afternoon. Yes. Starting at 2, ending at 7.
Yeah.
So I'm collecting some cases. There's some
Uh-huh.
cases which have already operated, some no improvement, and then some cases which are, total palsies, partial palsy, all of them. So we can discuss them. And
No, so it will be, you are going
yes,
to record
as
the
it is-
examination and
Yeah.
present it in PowerPoint, or are you going to?
I'm trying to see, we can get a couple of patients too. So we'll
No,
spend.
I generally do not like
Okay.
the patient being brought.
Okay.
Because it makes up for a spectacle and everybody wants to examine, it becomes uncomfortable for the patient. Okay.
Okay. No, the faculty can examine and show the findings.
So what I would suggest.
Okay.
Since we are all coming in this starting in the afternoon, right?
Okay.
So we can record the examination, answering all the questions. If you get what I mean.
Got it.
It is the sort of questions we are going to address today.
Got it.
Are the videos that we record. We'll check them all beforehand, so that no question goes unanswered.
Right. Got it.
Based on the clinical grounds.
Yeah.
Okay.
And each of the faculties can bring in some cases for discussion. Yeah.
Yeah. So this is the way I always record all my videos.
Okay.
And it's always done in a systematic manner. And every video that I record is always for presentation.
Okay.
So therefore, I always think first whether the what will be the question asked about this video.
Okay.
And I see to it that my gestures in recording the video will answer the question. That the question should not arise in a person's mind.
Got it.
Okay. So let us do it that way, I hope, so that we don't have this business of actually physically examining a patient in front of a lot of people.
Okay, because there's a small crowd of 30 to 40 in the workshop.
Yes, but still it is after all a spectacle, right? People will be sitting in the audience and the patient will be brought in front of them. That I'm not very keen on.
Okay. At the same time, of course, we'll have a video presentation of pre-op and yeah.
Yes, I agreed. But see, when we are discussing strategies, is discussing outcomes, discussing methods of tackling a failure.
Got it.
Really don't want the patient to be there.
Yeah.
That is my personal feeling. I don't know what Piyush says about this, but
that's okay. Anyway, it's not a live workshop, so it's so that we can have a recorded pre-op video, not an issue. You can have a recorded pre-op in detail examination, and then
then the uniform method of examination will be drilled into people, that they should not end up saying, oh, the shoulder abduction, elbow flexion is not there, so therefore it is a C5 C6, and therefore we will do a triple now or a quadruple now transfer. This is a sort of nonsense I heard in Chandigarh, and I cannot understand people who want to present that, okay, we have also started doing brachial plexus. They are saying that 50% of our cases are total palsies. Then why the hell are they presenting only outcomes of partial palsies? Be patient. You don't have to show your best results as quickly as possible. I don't think that is a very good idea that has been encouraged in Chandigarh. And we should cultivate more centers for brachial plexus surgery rather than centers for nerve transfers.
So for the 5 hours program on Saturday, on 28th, so how many hours do you want for discussion? And then if you're getting in Wang to talk, if in case he's not able to come, we'll have it on recorded videos or live also.
We should give at least half an hour to him.
Okay. And then Dr. Clifton, he's also coming online.
Yeah, he will also come online. But I
Yeah.
will, since the time in the afternoon is totally unsuitable for him because it will be the middle of the night for him. He's 11 and a half hours behind us.
Yeah. Can
So
you have a recorded?
So we will get him to record a video and send it across.
Okay.
So half an hour for each.
Got it. You
So
think 5 hours should be
out of the 5 hours?
Yeah.
Let us say Wong will be there for discussion.
Yeah.
With his son being be there to interpret.
Okay.
And I don't think if maybe at a stretch towards the end of the day we can have Clifton coming online to answer questions. Because 7 o'clock our time in the evening, he will have woken up. He can answer.
Perfect.
So we can discuss with him so that we can play the video, recorded video just before the discussion, and he wakes up and comes on for discussion.
Perfect. And since it is a focused grow, so we can we are a little flexible to start at 1:30 and then end up by 7:30, 8 also. If in case
it is our program, so we can
exactly. Absolutely.
Piyush, तुम्हारा क्या कहना है कि should we have patients inside the auditorium or not?
You have to unmute yourself, Dr. Piyush.
No. If we have the patient, it is good, but otherwise videos is really good because we can show at least 3 or 4 varieties of cases. Okay, why it is like this, why it is like this.
No, the question here really is that he is making this as a case-based discussion. Okay. So there will be problem cases. That is simple problems and
exactly. Both ways. Patients not operated, patients operated, both ways.
Simple problems will be one that this is the diagnosis and what will you do?
Yes, correct.
And complex problem is that this was already done and this has not worked. So how will you address this issue, right? So I personally feel that we should have a recorded video of the examination. We really don't need to have the patient present for that.
Yes.
Okay, let's plan it in the next few weeks, I guess, no?
Yeah, we have got time. That's for next month.
You got time, and it is difficult to collect all the varieties of cases probably to be present there. Then one case we have got and we discuss on that continues. It will not serve the purpose.
It will take time, exactly.
Yes.
Yeah. 5 p.m. Yeah. Nancy?
Yes, doctor. So let me start, doctor.
I think so. We have 25 of them who come in. Yeah.
There is actually totally 35.
Okay.
Including the Zoom platform as well as GHA platform.
Okay. Can we start? We are waiting for Dr. Srikanth, and you called him, right? Dr. Srikanth and Dr. Purushottam.
Doctor, totally there is 40 participants.
Yeah, Dr. Srikanth and Purushottam, you called them, right?
Yes, he was saying that he is on the way, so he will be joining.
Yeah, just as a coordinator, start off and hand over so that we'll continue because Dr. Bhatia will be starting his first presentation, case discussion.
Sure, doctor. So let me introduce.
Yeah.
You will be presenting first.
Okay. Okay. Got it.
We will start with the partial palsy.
Okay. Got it. Yeah.
Okay.
Right. Yeah.
So let me start. Good evening, everyone. I'm Nancy Johnson from Global Healthcare Academy. So going to the next slide, just 2 minutes. So Global Healthcare Academy has been instituted with the mission to develop competent and compassionate human resources for the healthcare sector. GHA also promotes innovative solutions and enterprises in healthcare. Our core purpose is to bridge the skill and knowledge gap between formal education and needs in the healthcare industry. The distinguished features of the GHA training include the following: intensive intense collaboration at every stage between practitioners and tutors, from conception and formulation of training program, enlisting of faculty with sufficient work experience, case-based learning from real-life situation, and practice-oriented learning methodology. GHA is lead managed and advised by reputed doctors and healthcare professionals. It's my pleasure to introduce Dr. Bharat K. Kadadi, who will be delivering the section on brachial plexus cadaver. Dr. Bharat K. Kadadi, I wish you a warm welcome to the session. So let me...
Yeah. Thank you, Nancy. That's fine. That's okay, Nancy. We'll just
Sure.
move on. That's fine. You can put on the slides on the side. Hi, all. Pleasure to see you all this evening. We have participants in good number this evening. So, all of you are aware that we have the cadaver workshop at the Ramaya Advanced Learning Center on 28th of October and 29th of October. One full day of cadaver dissection. Prior to that, we have our case discussions mainly. And we'll also have the international faculty to present some recent advances in the treatment and management of brachial plexus injuries. So what we observed is case discussion will be very useful in terms of your people who are practice. The whole idea of having this webinar is to see, would like to know how many of you are been doing brachial plexus for less than 5 years, more than 5 years. We need to cater to your needs for the cadaver workshop, and that's the whole idea. Today we have started off with our discussion, and you can pile up your questions so that we'll be able to answer. We have a team of faculty here. Dr. Anil Bhatia, all of you know him, Dr. Piyush Doshi, and of course, Dr. Srikant, Dr. Purushottam, GB sir, they'll all be joining shortly, Dr. Darshan. Yeah. So over to Dr. Piyush for the first case discussion. You can share your slides.
Fine. Yeah, can you see my slide presentation?
Not yet.
Yeah, this is the first slide is the same. Okay, you can see it.
Yeah,
so,
got it.
hello, friends. I'll be talking about the partial palsy and specifically involving about the extended partial palsies where more than 2 roots are injured. So there are different varieties of presentation in extended partial palsy. So in any patient, all these cases, you can see that there is loss of shoulder abduction and external rotation along with loss of elbow flexion. But any deficit more than this and hand function and intrinsics are preserved, it is extended partial palsy. So this is the case. He has presented with a loss of shoulder abduction, external rotation, and elbow flexion. And the hand function looks full. So it essentially looks like a C5, C6 palsy. But the further investigations shows that the pectoralis major is weak. You can see it again. Only the lower pectoralis major is working. And lat dorsi is absent. Triceps is there, but it is weak. So that is that, and this is the wrist dorsiflexion. Now you can see that he is able to do dorsiflex the wrist, but he is using the finger and thumb extensors to dorsiflex the wrist. So to confirm that, you have to palpate at the level of the second metacarpal and look for the contraction of the ECRB and ECRA, whether it is functioning or not. So basically, when C5, C6 roots are ruptured, you have got the loss of supraspinatus, infraspinatus, biceps, and deltoid. But when you have got more than 2 root injury, you will find that you will lose the serratus anterior, pectoralis major will be weakened, lat dorsi may be weak or absent. Brachialis is always absent, but triceps, ECRL, ECRB, may be absent, and FCR on the wrist will be absent. So these are the signs where you suspect that this is an extended partial palsy, and this is really important because it will change the management. Okay, so this is a case of 25-year-old male with hand function preserved. And you can see there is no FCR. Palmaris longus and FCR are visible. Triceps is almost zero. And there is no wrist dorsiflexion. So this is the clinical examination. Has anybody got any questions right now? So should I go ahead with the surgery part?
Can you just put up this video again, Dr. Piyush?
Yeah. Where is my cursor?
Yeah.
So this is shoulder abduction and elbow flexion. You can see the palmaris longus and FCU.
Piyush,
Yes, sir.
so what we wish to emphasize is that mere loss of shoulder abduction, external rotation, and elbow flexion is not enough for us to go on. A detailed evaluation is necessary. Can you go back a few slides and tell us a bit better about your evaluation of the pectoralis major and of the latissimus dorsi?
Okay. So basically, you hold the upper limb and resist the adduction of the limb. And you can be able to see the pectoralis major here. So when whole pectoralis major is I have put a really small video. I'm really sorry for that. I've cut short that video. But you'll be able to see the whole pectoralis major is contracting. Usually in C5, C6 palsy, the weakness is very minimal or almost there is no weakness. But when there's extended partial palsy, in most of the cases, you will find that the upper pectoralis major is not functional and only the lower part of the pectoralis major is functional. That is the one differentiating sign. For lat dorsi, you hold the limb in this position, or you can even hold in forward position only, and then ask the patient to pull back, just like we do in gym, like lat pull back, and feel at the posterior axillary fold at the level of scapula angle. And you can see the contraction, or you can even feel the contraction. And when lat dorsi is absent or lat dorsi is really weak, again you have to suspect that there is more than two roots are injured.
Perhaps I would like to add to this is that retropulsion from the front of the body to the coronal plane, that is retropulsion of the arm from front of the body up to the coronal plane with palpation below the inferior angle of the scapula.
Yes.
Is what I would emphasize. Because the teres major and lat dorsi are indistinguishable at the posterior border, at the lateral border of the scapula. But the latissimus dorsi is the only muscle which is extending below the inferior angle of the scapula. And therefore, in this action of retropulsion or even resisted adduction, one should palpate below the inferior angle of the scapula to be certain that the latissimus dorsi is functioning in an optimal manner or not. These patients lack rotator cuff and deltoid function, and therefore and also the long head of biceps. Therefore, the head of the humerus is not located exactly adjacent to the glenoid. They do not have enough leverage to adduct or retropulse the arm, and therefore the latissimus dorsi may not be easily evident unless we hold the arm and provide resistance.
Right.
I'm just clarifying. You and I
Right. Yes.
know all these things as part of our DNA, but
Yes.
this is something that we need to emphasize in the manner of clinical examination.
What about the serratus anterior, Dr. Piyush?
Serratus anterior, I have not shown in this video series actually.
Because considering the kind of involvement in this patient, I think that becomes a very important.
I will be speaking on that in when I talk about total palsy.
Yes, please go ahead.
Okay.
So, Piyush, to cut the long story short, what are your priorities for restoration of function in this extended partial palsy?
So the priorities will start once I explore the plexus.
No. When my question to you is this.
Yeah.
You're lacking shoulder abduction, external rotation, and you're lacking elbow flexion.
Right.
At the level of the shoulder, which is the muscle group of muscles that you will give priority? Is it deltoid or is it the rotator cuff?
Yeah, I will give priority to the rotator cuff. So, but
why would you do that when the rotator cuff is such a flimsy group of muscles? Why do you want to innervate the rotator cuff and not the big bulk of the deltoid?
See, basically the humerus head has to be stabilized against the glenoid, and then only the true abduction is possible. So, and that can only be achieved by rotator cuff. And you can add something more to this.
I think I lost your audio.
Hello, can you hear me?
Yes, I can hear you.
Carry on.
Yeah.
Yes. So rotator cuff is the primary initiator of the abduction because it holds the humeral head against the glenoid. And if it is not held against even if only deltoid is functional, there is actually no abduction. And that we have seen in some cases of the true supraspinatus nerve injury. So supraspinatus to re-innervate is the first priority. And then if we have got additional nerve donor available, then we can use it for the deltoid. So the priority is like this. And another important thing here is the serratus anterior. So if C5, C6, C7, all the three roots are avulsed and there is no serratus anterior, then I will give more importance re-innervating serratus anterior rather than deltoid.
So if you have an option of doing a nerve transfer for the deltoid or the serratus anterior, which would you prefer?
I'll prefer it to give to serratus anterior because the scapula will be more stabilized. So whatever little abduction or 30-degree abduction you are getting against by supraspinatus, it will improve. And there is a possibility that, see, in the spinal axis to suprascapular nerve transfer may not give in every case infraspinatus. But whenever it gives infraspinatus, if I have re-innervated the serratus anterior, the patient will gain a good external rotation also. So it is very important that I will re-innervate the serratus anterior rather than deltoid.
Right. Got it.
Then at the elbow, let me, Bharat, this idea of this webinar basically is to highlight our philosophy. So let us rapidly go to the lack of elbow flexion. Okay. Now, the address, how would you address the elbow flexion? Your options are an available root stump being grafted to the musculocutaneous, spinal accessory now being grafted to the musculocutaneous, a single or double fascicular now transfer for biceps or brachialis. So among these, which would be your preferred and why?
See, I usually prefer when the hand function is good, then I will go for a double fascicular nerve transfer. because this is the nearest transfer and the success rate is really good with this. If hand function is not good, and then I will think of other options. But again, in majority of the cases where I feel that spinal accessory is used for the shoulder stabilization rather than for the musculocutaneous now. So I will prefer to go for intercostals in the case of the hand is really big. Then I will use intercostals to musculocutaneous now for the elbow flexion. And if I get a root, again, I will usually use the root for the strengthening of the shoulder. So I will use it for the posterior division of the upper and middle trunk, which will strengthen the shoulder and the weak triceps.
And what else would you like to reinnervate? Most of these patients, in my experience, have needed a tendon transfer for wrist dorsiflexion, independent wrist dorsiflexion, secondarily. That is before 2013. In the last decade, we have changed that. So the how would you address the
for wrist dorsiflexion? See, in all these cases, most of the time the independent wrist dorsiflexion is absent. Sometimes wrist dorsiflexion is present, which is being used by finger and thumb extensors. So actually, when you make a video, you can see that there is something wrist extension is there. But whenever patient actually uses the hand goes in flexion. So it is always better that we have to reinnervate the independent wrist dorsiflexion, and the nerve transfers from pronator quadratus branch of anterior anterosseous nerve can be directly transferred to the branch to ECRB. And again, this can always be confirmed during surgery that you dissect the ECRB branch, stimulate it and confirm that it is not functioning. And the rest of the posterior anterosseous nerve is giving stimulation. So that means you are 100% sure that you are reinnervating a paralyzed ECRB in this particular case. And this nerve transfer is again gives a really predictable result.
Fine, so let us see the rest of your slides.
So this is a case. And this is a dissection. This is the phrenic nerve. And there's a C5 root. And the C6 and C7 roots are absent there.
So can you orient us?
Yes. So this is the head end.
Please hear me out.
Yes.
Do you do a transverse supraclavicular incision systematically, or you incise along the sternobastroid and along the clavicle?
I incise along the sternobastroid and along the clavicle so that the V flap hole is completely raised, and this fat over the supraclavicular fossa are dissected out. Usually the EJV may be preserved or may be cut depending upon how the dissection proceeds. And once I have reached to the anterior surface of the scalenus anterior, I'll be able to see the phrenic nerve. And once I see the phrenic nerve, I go medial to it, and you can see that this muscle has been dissected, scalenus anterior. Because most of the time you have to dissect some part of the surface of the scalenus anterior to see the root. And once I have identified the root, usually in this photograph it is not visible, but we can see a branch from this root somewhere here, going posteriorly, and that is a branch to serratus anterior. So stimulation of this root, like this is here, you can see it, and it gives a good response to the shoulder, the serratus anterior.
And in nothing else.
And nothing else, yes, right. So you can see the video again.
This stage in your dissection is after you have visualized the upper trunk, seen that it is scarred in the interscalene area, worked your way backwards to confirm that there is no physiological continuity of the C5 to the upper trunk. Is that right?
No, I usually do this dissection first to begin my plexus exploration at the root level. And once I have found the root or not found the root, and then I go downwards, at the level of clavicle and start dissecting from the suprascapular nerve upwards.
No, I'm just putting it, acting the devil's advocate.
Yes.
I'm just extrapolating what we do in birth palsy to this, that we isolate the entire upper trunk, note that it is scarred in the interscalene area, and you have noted that there is a root feeding it medial to the scarred area, which can be traced up to the intervertebral foramen, and dissection in the intervertebral foramen is relatively easy as compared to the dissection of the scarred upper trunk.
Yes,
Then,
very true.
You have looked at the serratus anterior branch and traced it to the long thoracic nerve as it exits from the posterior border of the scalenus medius. Having answered all these questions in your mind, you have stimulated the C5 and found that it is not stimulating anything else except the serratus anterior. Am I right in following you?
Yes, sir. Right.
So please proceed.
Yeah. So once we have identified in an extended partial palsy, one root is available and it gives a good response to serratus anterior. So now one portion of our surgery is done, that serratus anterior is preserved. So now I'm not worried about re-innervating the serratus anterior. So now whatever donors available to me, now I will start thinking about in a different ways. So in this patient, this C5 root was now grafted to the posterior division of upper trunk. The spinal accessory nerve was repaired with the suprascapular nerve, and double fascicular nerve transfer were done, and anterior traceus branch or PQ branch from PQ branch to the ECRB nerve transfer was done. And this is at the 43 months. These triceps may have some spontaneous recovery.
What are the status of the C7 in this patient? C7?
C6 and C7 are avulsed, and I did not dissect C8 specifically in this case, though C8 looks damaged because at the pre-op evaluation, triceps was 0. So I suspect the C8. Even the finger and thumb extensors were very weak in this patient, if you have seen the pre-op video. So but then there is a possibility that some C8 function might have recovered. Even if you look at this video at the end, these triceps may have some spontaneous recovery from the C8. See, his finger and thumb extension is still not full.
Were you able to stimulate the C8 on table?
No, it gives response to hand function only. Basically, I usually dissect it out, but not completely dissecting it, because when the hand is functional, I will not touch the lower trunk much. I'll just identify it and stay away from it.
So the shoulder function here, we have got it from the spinal axis to suprascapular, and along with the C5 to the posterior division of the upper trunk, right? Right.
Yes, right. Yes.
How many centimeters was your cable graft from the?
It must be around 6.5 centimeters.
How many? 3 or 2 cables?
Usually 3 or 4 cables. In this patient, it must be 3 cables.
That's excellent. Any other? There are some questions in the chat box. Can we answer them now, or shall I ask one of the faculties to?
We can answer them now, because going back at the end is going to be difficult.
Okay. Okay. There's one question. Do the pectoral nerves arise from the roots or the trunks? In text, we read that there are no branches from the trunk.
Yeah. So the pectoral branches usually, we have seen that it is arising from the trunks. And we have seen routinely that there are not 2 pectoral branches, but 3 pectoral branches. One is coming from the upper trunk, one is coming from the middle trunk, and one is coming from the lower trunk. So whether to say it is a medial pectoral or lateral pectoral, now it is very difficult to say. It is not there. But then every trunk gives the branch to pectoralis major, and they are usually at just behind the clavicle, or at the level of clavicle only. So whenever we do contralateral C7 transfer, we can see the pectoral branch coming out of the C7 trunk.
Another question by Dr. Jitin is, how do you check serratus anterior contraction intraoperatively? I think that you already made it very clear with your video when you stimulated the serratus anterior, which is contracting. Yes. Right? Yeah, because the contribution from the C5 to the serratus anterior was able to see the contraction. So you just stimulate the serratus anterior exiting at the behind the scalenus medius and check.
Yeah, yes. Purushottam sir, you can ask a question, please.
Yes, Dr. Purushottam sir. Yes, Dr. Srikanth is there. I think if there are no more questions, we can go on to the next case discussion.
Yes.
Thank you, Dr.
Yeah, I will stop sharing the screen.
Yeah, we'll have to unmute Dr. Purushottam, or Nancy, you can make him the host. Dr. Purushottam, we'll have to unmute him, and please, or we can make him the host so that he can unmute himself. Thank you, Dr. Piyush, for the excellent clarity in presentation, and so that we understood a lot of points in terms of extended brachial plexus injury, what options we have.
So it is very important in extended partial palsy that you do not have triceps to deltoid transfer available with you. That is very important. So once you find that C7 is injured, C7 is avulsed, we should not attempt to do triceps to deltoid transfer, which will it will further weaken the triceps and it will not give us the desired result in the deltoid. So that transfer is not available in extended partial palsies.
Thank you. Nancy, can you, Dr. Purushottam, yes, sir. I think you're unmuted now.
Can you hear me?
Yes, sir.
Piyush?
Yes, sir.
Triceps is working or recovered. Yes. Finger extensors have recovered.
Yes.
And how do you say the wrist extension is only by your pronator quadratus to ECRB? That also could have recovered. ECRL could have recovered, no?
See, basically, we can see the contraction of the ECRB. And say whatever recovery occurs, it occurs from the C8 root. And the C8 root does not give rise to ECRL or ECRB. And
no, triceps has recovered.
Yes, triceps has recovered. I will say triceps has recovered because my grafting will help the triceps to recover. But then it is not always, I cannot put it completely that this triceps is completely from the now grafting only from PDUT. Because C8 is there is always some spontaneous chances of spontaneous recovery in C8. I have seen that in some extended partial palsy. And I have faced these problems. Like once in a case, I did a grafting to radial nerve. And then I missed the chance of spontaneous recovery. So usually I do a grafting at the posterior division of upper trunk and middle trunk and don't go almost up to the radial nerve in most of the cases now. So there is always a scope of some recovery because we have seen even in T1 hand, we have seen triceps to be preserved in many of the cases. Okay. So there is always a chance of spontaneous recovery of triceps. And that is the reason in extended partial palsy, triceps is the last priority to re-innervate. Second thing is that ECRL and ECRB is purely from C5 and C6, C5, C6, C7. And that is what we have confirmed clinically in C8, T1 clump case palsy also, that in most of the cases, you will find that ECRL, ECRB are functional. So in C8, T1 palsy, we don't see wrist extension to go. So that is the reason main I say that even if there is a spontaneous recovery in finger extension and thumb extension, or there is in triceps, it will not recover independent wrist dorsiflexion, and it is always better to re-innervate it. Yes, we can see by clinically, post-operatively, when we evaluate the result, we can see the contraction of the ECRB when he is dorsiflexing the wrist. And usually it is very clearly seen, and that is why we take the video in this angle, because you can see the dorsal forearm where you can see the contraction of the ECRB muscle, sir.
Thank you, Piyush. Excellent results.
Thank you very much, sir.
May I just add a word which Piyush did not vocalize? It's something that he and I have shared for 20 years now. That in a upper or a partial brachial plexus injury, supraclavicular, the mobile WAD is 0. There is nothing in the brachiodalis. And if it is an extended partial palsy, there is nothing in the ECRL, ECRB either. So if in the mobile WAD, you see a muscle contracting distal to the level of the lateral epicondyle, it can only be the ECRB, and it can only be innervated from the branch that we have innervated using the anterior interosseous nerve. And therefore, we cannot really say that it is spontaneous recovery that produced wrist dorsiflexion. Here, the independent wrist dorsiflexion can be solely attributed to the nerve procedure carried out.
Right, sir.
Unless you prove it by a negative EMG of ECRL, only then probably it can be confirmed. If you want a authenticate confirmation, you do a EMG of ECRL, and if that is negative, then probably the only thing which is extending the wrist is probably ECRB.
Yes, but then even ECRL will come. Yes, I have done the nerve grafting from C5 to PDUT, so there is a possibility of recovery of ECRL. I agree with you in that case. So because I have done a nerve grafting, otherwise in C5, C6, C7 avulsion, then it is only the ECRB. We don't have to look for the ECRL EMG.
Yeah.
Okay.
No, I agree with that. I agree with that.
Thank you.
Because,
yes.
Thank you.
Yeah. Can we go on to the next case discussion from Dr. Anil Bhatia?
Right.
Yes.
I have not made it as crisp as Piyush did, but I'm going to be talking about post-traumatic. This entire discussion is about post-traumatic closed traction injuries of the brachial plexus, and we are taking one step back from Piyush's presentation. We know that when nerves are subjected to closed traction, beyond a certain level, they would get disrupted. It is very important to understand the anatomy of the roots as they arise from the spinal cord. And the dorsal root ganglion is extremely important for us to understand where the injury happens in the supraclavicular fossa. So if the injury is proximal to that, that is avulsion of the rootlets from the spinal cord, which is considered to be proximal to the dorsal root ganglion, therefore it's a preganglionic injury. Therefore, the sensory component distal to the dorsal root ganglion will not undergo Wallerian degeneration. But it is likened to the plugs getting pulled out of the socket. On the other, which would look something like this. We are talking of a disruption of all 5 roots. The only thing that is functioning is the trapezius, which is innervated by the spinal accessory nerve. In some very severe cases, even the sternomastoid and trapezius do get paralyzed. But here we are talking about an avulsion of all 5 roots, and only muscle that is functioning.
Okay.
The only muscle that is functioning is the trapezius. An important sign here is the Horner sign, which would indicate an injury very proximal to the cervical sympathetic outflow, whereas if the injury is distal to the dorsal root ganglion, that is the post-ganglionic injury, it implies that at least the ventral rootlets retain their continuity to the spinal cord and can provide donor axons in the visible root stump in the neck, which would become evident like so. As I promised you, Bharat, the method of examination of the serratus anterior, I would like to highlight here. The limb is too heavy for the serratus anterior to move, so you must cradle the limb. The examination is from the back. you are trying to look at the movement of the inferior angle of the scapula along the rib cage. Now, you might say that this is being enabled by the trapezius, but the trapezius cannot move the inferior angle of the scapula. It can only move the superolateral angle of the scapula. The movement of the inferior angle of the scapula would, by definition, require the contraction of the serratus anterior, which is inserted on the medial border of the anterior aspect of the scapula. So, if the inferior angle of the scapula moves along the rib cage when the patient attempts to move the limb forward, then we can suspect that at least part of the innervation of the serratus anterior is preserved, which would indicate that the first branch of the C5 or C5 or C5 and C6 roots is in continuity with the long thoracic nerve. To reiterate the same point, you see the inferior angle. This patient had a completely flail left upper limb, but you can see clearly that the inferior angle of the scapula is moving forward and backward along the rib cage. And to confirm that the patient had a total palsy, you can see that he had a Horner sign. So this is, in a sense, what we have to look for. We have to look for the ptosis, meiosis, enophthalmos, and decreased sweating on the ipsilateral half of the face, which are all signs of a stellate ganglion block or a interruption of the cervical sympathetic outflow, and which in post-traumatic cases can be taken to indicate a very proximal injury to the C8 and T1 roots. In the presence of a flail upper limb, at a month from the accident, the presence of a Horner sign would confirm a suspicion of a violent injury in the posterior triangle, and therefore the expectation for spontaneous recovery is 0, and one should indicate surgery. The Tinel sign is one other sign that I use regularly in my clinical practice. The Tinel sign is evocation of paresthesia in the sensory distribution of a given nerve on application of pressure on the surface marking of the nerve. This application of the Tinel-Hoffman sign for brachial plexus injuries is basically to look for or suspect a ruptured root in the neck before exploration, and the presence of serratus anterior is one sign. But if pressure is applied at the posterior border of the sternomastoid and it evokes paresthesia in the sensory distribution of the C5 or C5 and C6 roots, then one might suspect that there is a ruptured root at that location. It is not a foolproof sign. It depends upon cooperation of the patient, and therefore one cannot entirely rely on the Tinel sign. But it is a good sign for us to work on before embarking on surgical exploration. So this is how it should look. In the same patient that we had seen earlier, the serratus was present, and he indicates shooting pain in the distribution of the C5 root on palpation at the posterior border of the sternomastoid, at the site where clinically the external jugular vein seems to be crossing the posterior border of the sternomastoid. That acute angle is where the C5 root stump can be anticipated, as shown by Piyush earlier in the dissection as well. So this is what that would indicate that if the innervation of the serratus anterior is partially preserved or not. This patient they're taking that discussion one step further. Again, seems to have a flail upper limb, but there seems to be some movement in the shoulder. But the Horner sign is clearly evident. I'll just run the video again so that you can see his face. You can see that he has a Horner sign.
All
right. So
Yes.
it is a total palsy. It is a very proximal injury to the C8T1. Then what is happening at the shoulder? Your examination in the lying down position is important. When we cradle the entire weight of the limb in the examiner's hand, the patient is lying supine, therefore the scapula is held in place by the weight of the body. Therefore, the presence of supraspinatus function becomes clearly evident. We must remember that the supraspinatus is a muscle which is only 2 finger breadths in size. And therefore, to expect that to abduct the limb whilst the patient is standing is not a good idea, and it will not become clinically evident. Therefore, one must need, in addition, examine the patient lying down and to make the supraspinatus function evident. So in this case, we suspected that the upper trunk was injured distal to the origin of the suprascapular nerve, whereas the C7-8T1 were avulsed. The reason I'm saying that the C7 also was avulsed is that there was nothing in the pectoralis major, only the supraspinatus was functioning, and on exploration, this was the condition. The phrenic nerve, as Pius highlighted, the phrenic nerve was exposed first. The C5 and C6 roots, as they emerge from the foramina, the anterior and posterior divisions of the upper trunk were ruptured at the level of the clavicle, whereas the suprascapular nerve stayed in continuity and was stimulable. And dissection in the deltopectoral region confirmed our suspicion of avulsion of the C8 and T1. What we are seeing is the posterior cord here. This is the posterior division of the lower trunk as it joins from the lower trunk into the posterior cord. And this is the situation of the lower trunk behind the clavicle, which was now delivered below the clavicle. So detailed clinical examination will help us guide us in our surgical exploration. Now, we are committed to approximate the ruptured roots we find in the neck or the contralateral C7 to the target nerve. For us, the target nerve most important after the rotator cuff would be the elbow flexion and dysfunction distal to the elbow in the patients younger than 35 years. Now, we want to as opposed to 65 years of training in nerve surgery, we want to mobilize the nerve ends so that the interposed nerve graft is eliminated. For that, we would need to mobilize the nerve ends, no doubt. We would need to reroute the nerves. We would need to sacrifice certain non-essential branches so that only the continuity to the branches that interest us is retained. We need to adduct the arm across the chest in order to reduce the tension at the repair site. And finally, if all these maneuvers are not enough, we would need to shorten the skeleton to a reasonable extent. This has been found to be up to 14% of the length of the humerus, which can be tolerated so that the biceps does not become too slack to be effective in flexing the elbow. If we shorten the humerus more than that, then even if we achieve a good innervation of the biceps, the elbow flexion will not be regained. So shortening of the humerus is a part of our plan when we have finished dissection of the roots and trunks. Now, all these aspects have been encapsulated in Wong's article of 2013. Sorry? Do I continue?
Yes. I think it's Nancy, you can unmute all of them, I guess.
They mute all of them.
Mute all of them, sorry, yeah.
Yes,
please.
We need to mobilize the lower trunk proximally and approximate it to the opposite C7 by pre-spinal root. The loose end of the medial cutaneous nerve of the arm and forearm, which will have to be divided in order to mobilize the lower trunk, is then approximated to the musculocutaneous nerve, so that the contralateral C7 growing axons not only will be directed towards the finger flexion and wrist flexion, but it would also go towards the innervation of the musculocutaneous. In addition, we add one sural nerve graft cable from the pectoral branch of the C7, as indicated by Piyush earlier, which is also bridged to the musculocutaneous nerve. The phrenic nerve is connected directly to the posterior division of the lower trunk, and the spinal accessory is connected to the suprascapular for innervation of the rotator cuff. So effectively, we are addressing shoulder abduction, adduction. I add pectoralis major as well. So adduction, elbow flexion from the opposite C7, elbow extension from the phrenic to posterior division of the lower trunk, finger flexion from the opposite C7 to the anterior division of the lower trunk, and finger extension from the phrenic nerve, hopefully, to innervate the extrinsic finger extensor. Now here, I would like to indicate what Piyush had said earlier. From our dissections of the lower trunk, we have found that the posterior division of the lower trunk systematically arises from the C8, and the posterior division of the lower trunk innervation almost in 90% of our cases is successful for reinnervation of the triceps. In only 4% of cases, we extension our procedure. It involves systematic dissection in this scarred and broken end of the trunks, which for a lot of time we were not exploring in the past. The suprascapular nerve is a valuable source to enter the scarred area, so that we can discern the upper trunk, and then from there the middle and lower trunk can be reached. So there we can achieve a dissection of all the trunks in this manner. We might need to shorten the humerus, and then we can approximate the anterior division of the lower trunk to the contralateral C7 in the pre-spinal root. And it is also bridged to the musculocutaneous. Now, the first lady who was operated by this technique achieved this abduction and external rotation from the innervation of the rotator cuff. Elbow flexion came from the opposite C7. Elbow extension from the phrenic nerve. Finger flexion from the opposite C7, and finger extension from the phrenic nerve. Now, of course, secondary surgery has been done. Wrist and radioulnar joint have been fused. We have to remember that she is not making any significant gesture from the opposite side in order to flex the fingers. So the contralateral C7 innervation of the finger flexors does not require synchronous gestures from the opposite side at long term, and therefore the contralateral C7 transfer for finger flexion is a valuable resource. But it is valuable when we do a direct repair, not when we have interposed nerve grafts. So this patient could achieve independent manipulation of objects in space without any visible participation of the opposite upper limb. Another patient, again, the same sort of avulsion of all 5 roots, the same sort of plan. But in addition, I innervated the pectoralis major. Which at 22 months has given this sort of abduction, elbow flexion from the contralateral C7, again not requiring any gesture on the opposite side. You can see that he's not moving the opposite upper limb at all in flexing the elbow. The wrist and finger flexion, although it is feeble, it is being activated from the opposite C7. And when he takes a deep breath, there is almost grade 3 function in the long head of the triceps. When he flexes the elbow and wrist and fingers, he doesn't need to engage the opposite upper limb, he can do it independently. And after secondary surgery, again, prehension is achieved. That is, he can manipulate objects. So, in the current state of the art, in a patient who is less than 35 years of age, this is what we have to aim for. Systematic and the essential prerequisites are detailed clinical examination, detailed dissection, and after that, application of the techniques that we know. I think I'll stop here. We'll take some discussion on this.
Right. Thank you, Dr. Anil Bhatia. So the results what we have seen in the classical Wang's procedure in total avulsion of all the roads. Now, the same patient, if he has a C5 rupture, which are available root, and avulsion of 6, 7, 8, and T1, what would you do additionally? With the same a total paralysis,
yes,
flail upper limb, C5 root ruptured, available for repair, avulsion of 6, 7, 8, T1. What would you do?
For a long time, I was not happy about using the contralateral C7 for elbow flexion in addition, because it essentially implies that we have interposed nerve grafts for the most important function, that is elbow flexion. So, rather than depend upon the contralateral C7 to provide elbow flexion as well as finger flexion, in the past, in younger patients, I have used the C5 bridged by nerve grafts for to the musculocutaneous nerve for elbow flexion. So that is the utility when I have a ruptured root, and therefore that can be harnessed as well. During the Baroda meeting, Wang presented his results of attempting to restore finger extension. When we have a distinct root which is available in the interscalene area, not at the foramen, but a distinct length of ruptured root available for approximation to the middle trunk, that is a worthwhile alternative to the use of the ruptured root. I've already done it in 2 cases, but of course, we have done it in the past 5 months after the Baroda meeting. So we'll have to wait for maybe the end of next year to be able to give any additional information in our experience. Piyush also has done 1 case recently. So let's see what we get next year.
That means you have used the available ruptured C5 to C7 directly, ipsilateral C7 directly.
Yes. So that it is direct. So it will be directed towards the triceps and hopefully further down to the finger extensors.
Yes.
So that the likelihood of finger extension is better than the 4% that we are getting from the phrenic to PDLT currently.
Got it. Can we innovate the posterior division of upper trunk with C5 for better shoulder stabilization, or you think spinal activity suprascapular enough if you have available C5 in addition to what the procedure you have done?
The posterior division of the upper trunk is not a target that I favor for total palsies. I have found that innervation of the pectoralis major is far simpler, and that I incorporate systematically. Deltoid is not a muscle that I favor very much in a total palsy.
Because we got quite stable shoulder with spinal activity suprascapular.
Essentially the weight of the limb has become reduced considerably because of the paralysis of all the muscles. So it is the skeleton that has to be moved, and the innervation of the rotator cuff is a non-negotiable minimum, and it does provide reasonable stability in our experience.
Yeah, just a question. At what level does he cut scalenus anterior muscle to identify C5, C6?
I'm sorry?
There's one question in the chat box.
Yes.
At what level does he cut scalenus anterior to identify C5, C6 root? What precautions does he take to cut?
No, we don't do it that way. I'm afraid Piyush was not very clear on this. The dissection starts with identification of the phrenic nerve. Okay. And when we have identified the phrenic nerve, we can easily see the posterior border of the scalenus anterior.
Absolutely.
And the interscalene area would contain the upper trunk or whatever is the remnant that is present at that level. So the sacrifice of the fibers of the scalenus anterior are only to facilitate the dissection of the root medially up to the foramen.
Yes.
There's no specific level I can say for the division of the scalenus anterior. We just want to highlight the exposure of the the root at the foramen, and therefore we go from the interscalene area backward, and whatever gets in the way we divide, preserving the continuity of the phrenic nerve.
For exploration of the lower trunk, C8 and T1, do you always require to divide this scalenus anterior?
No, it's not required. In fact, the lower trunk is not lying behind the scalenus anterior in an avulsion of C8T1. It is lying behind the clavicle. But it is lying inferomedial to the middle trunk and to the upper trunk. So, whatever, in order to reach the lower trunk, you have perforce to traverse the upper and middle trunks first. Now, all of them are lying avulsed and turned downward and medially. Therefore, we are looking at the convexity of the trunks. In that, identification of the suprascapular nerve is vital, and that we prefer to do at the level of the notch rather than at the level of the trunk. The suprascapular nerve can be easily identified by following the omohyoid. The omohyoid is inserted on the superior border of the scapula adjacent to the suprascapular notch. Therefore, if we follow the omohyoid, we can readily identify the suprascapular nerve in a relatively less traumatized zone, and from that we can trace it to the upper trunk and distinguish the posterior and anterior divisions and evert the entire upper trunk outward. It is only after we have mobilized the entire upper trunk outward can we actually reach the middle trunk and subsequently the lower trunk. This division of the scalenus anterior will only expose the subclavian artery. It will not expose the lower trunk in a case of a total palsy.
Absolutely. Any other questions to Dr. Bhatia? There's one question which says, which level do you divide? Any anatomical landmark to say which level do you divide the scalenus anterior? I think it's the same.
Yeah.
Any anatomical landmark at which level is scalenus anterior is divided? Yes. I think there are no other questions. Shall we go to the
if I might just give a rider to everything else.
Yeah.
I prefer to use the broken nerves as my guideline rather than the muscles.
Yes.
The only muscle that is relevant to me in all this is the posterior border of the sternum-mastoid. After I have identified that and retracted it anteriorly, it is going to be the nerves which are going to guide my dissection as I go. But as in all plastic surgery procedures, we go in normal area and go towards the damaged area. So we don't go messing around in the damaged area first, because then we might injure something which you don't want to injure.
Absolutely, that point is very clear. Thank you, Dr. Bhatia. Can we go on to the next presentation from Dr. Srikanth R from Nizam's Institute?
I'll just stop sharing first.
Yeah.
Yeah.
Are you ready, Dr.
Bharat?
Srikanth?
Yeah, I'll just share my screen.
Yes, please.
not able to do that. I'm getting an advanced sharing option. Can I share?
Yes, you can share. Nancy, are you there? You need to make Dr. Srikanth. You need to make Dr. Srikanth a co-host.
I made it, doctor, already.
Okay, because he needs to share his screen.
He can share it right away.
Can you just try now, Dr. Srikanth?
Yeah. I think I can now. I think you can see now.
Yes.
Okay.
Yes, doctor.
Yeah, fine. This was a case that I operated a couple of days back. I found it a bit interesting, so I'm sharing it. A 40-year male, inability, to use the right upper limb for 6 months. It was a road traffic accident. He had a closed forearm both bone fracture on the same limb, operated 2 or 3 days after the accident. But he also had fractured ribs on both the sides and a fracture of the clavicle on the right side. And he had a ICD insertion for a bilateral pneumothorax. But he also had deep lacerations in the right axilla, and the skin suturing had been done. So I don't have videos here, but essentially what he had was he had a normal trapezius. He had shoulder abduction 3/5, 45 degrees. Adduction, he had 3/5. He had some stiffness and incomplete external rotation of the shoulder. The elbow flexion was 0/5, elbow extension also 0/5, and the passive range of motion in the elbow was only from 0 to 90, not the usual 135. As far as the wrist and fingers are concerned, there was no flexion, no extension. Both the MP joints and the wrist were stiff. The distal pulsations were normal. And he had a Horner sign on the involved side. I don't think it's very relevant to get an ENMG done once you can clinically assess the muscles and know whether they are paralyzed or not. It's done routinely, no doubt. But we have started using HRUS of the brachial plexus, especially in conditions where we are not very, very clear about the site of the lesion. In this case, the C5 and C6 were normal. C7 and C8 were thickened, but with no discontinuity. And as far as the infraclavicular brachial plexus, essentially they were normal, but there was an area of thickening of the posterior cord for 17 millimeters, and almost all the nerves which are distal to in the arm, they were normal. I had a doubt whether the lacerations that were there in the medial arm and the anterior axillary fold were deep enough to involve the nerves or not, which was why I got the ultrasound done. So the HRUS conclusion was C5, C6 is normal, C7, C8 is thickened, no comment about the T1, and there was an area of scarring on the posterior cord. So with this, we went in with a standard supraclavicular exploration. The C5 and C6 were stimulable and the SSN was stimulable in the sense that once you would stimulate the suprascapular nerve, you could make out the contraction of the spinati. And when we stimulated the C5 and C6, there was activity in the deltoid, but there was no activity in the biceps. The 7, 8, and T1, 7 was clearly avulsed, but held by scar to the intervertebral foramen. The 8 T1 was in continuity, but there was no stimulus in it. So having found this, we did continue with the infraclavicular dissection. The medial and the lateral cords were not stimulable at all. The posterior cord was not stimulable in the sense there was no activity in the radial nerve, but the axillary nerve was stimulable. And we could find 2 areas of injury, one in the lateral cord below the pectoralis minor and the musculocutaneous nerve, and the second one, injury in the posterior cord somewhere between the clavicle and the pectoralis minor. So this picture shows that there's a scarred lateral cord. This is distal to the pectoralis minor. And when we continued with an incision down into the medial arm, even the terminal end of the musculocutaneous was not good enough. It was scarred and it was thinned out. The scarred posterior cord is here. And in spite of the scar, which is proximal to the point of exit of the axillary nerve was stimulable, but there was nothing in the radial nerve. So I think this video will play. This was the intraoperative stimulation. Here we are stimulating the suprascapular nerve. And earlier what we stimulated was the posterior division of the upper trunk. This is the stimulation of the axillary nerve. So the deltoid was working. So before I go on to the next slide, so one is there was no movement in the hand. Two, there was no movement in the elbow. Plus, there was a background of the patient having bilateral chest injuries. And maybe I should ask the other panelists what they would do in such a situation, or I could directly go on to tell them what I did. So what I essentially did was, I had an intact shoulder, though there was some restriction of external rotation. It was more of the kind due to lack of therapy rather than any denervation. And I essentially had to restore function to the elbow with an injury in the lateral cord starting at the lower end of the pectoralis minor and going all the way up to the termination of the musculocutaneous nerve into the biceps, because I had opened the medial arm also to confirm that, and no activity on stimulation of either the lateral cord or the upper trunk or whatever. And so I decided I would do a gracilis flap for this patient with an arterial anastomosis through the thoracoacromial artery. And during the dissection of the lateral cord, I could find the lateral pectoral nerve. I took it as an alternative motor source for the gracilis instead of taking the spinal accessory nerve in the neck, which would be the standard one. And I made sure that the lateral pectoral nerve, whatever size I needed to match the nerve to the gracilis is what I took. And I didn't denervate the pectoral nerve completely, because the medial pectoral nerve would not be working since the C8 and T1 were not working. And essentially, we anchored the gracilis to the lateral border of the clavicle, looped around the biceps, and inserted into the ECRB. Now, this is what we did. I'm sure this is controversial. So I would request the other panelists to tell me if I went wrong or if they have something more to add to this. I'll stop sharing now.
Can I make a comment?
Yeah, please.
This is a standard infraclavicular injury because the patient had a laceration in the axilla. That means the injury was in abduction.
Yes.
The fact that the suprascapular nerve was spared is no surprise.
Yes.
The injury was behind and below the clavicle.
Yes.
Yes, the lower trunk was damaged at a very proximal level, and that is why you had no function in the triceps nor in the distal area.
Yes.
Personally, since you were operating at less than 6 months from the accident, the injury was in April, you're operating in September, so it's only 5 months. The patient is 40 years old, yes. So, grafting can be anticipated to work for the proximal muscles, but not for the distal muscles.
Okay.
So I would have perhaps given some priority to the triceps. I understand that you chose to innervate the elbow flexion using a gracilis. But for the gracilis, since gracilis is a very valuable procedure, I would never use a half-hearted nerve like one of the pectoral branches. The pec major to me is a very valuable muscle if it is already working. So I would never sacrifice that. So perhaps in your given situation, I would have, if I had a good team ready, yes, a gracilis is a good idea, but I would use it only for the elbow flexion, and I would innervate the triceps as well.
Okay. Can I ask you a question again?
Yes.
So, innervating the triceps using which donor?
Now, as you yourself said, the C5 and C6 roots were stimulable.
Yeah, but I know that the deltoid is already working.
Yes, but the deltoid is never supplied by the C6.
Right. So which means you would take the
in fact, I wanted to stop you there.
Yeah.
If we are assuming that the continuity of the upper trunk to the axillary nerve was preserved, I would check the latissima dorsi.
Okay.
What was the status of the thoracodorsal nerve? Because that inevitably arises from the axillary nerve. So if the axillary nerve was stimulable, I would be also checking the thoracodorsal nerve.
Yeah, I didn't do that.
And if that is available, then I would use that for the triceps.
Okay.
The thoracodorsal to triceps is an excellent nerve transfer,
Okay.
and has always worked in my hands.
Okay. Okay. So what would you have done for the elbow flexion?
No, I agree with your gracilis, but I would give it a spinal accessory now.
It was, okay. No, I need to point out here, it was not a big issue for me to use the spinal accessory nerve because that is what I do routinely. But I have quite a few instances.
But I do not agree. I do not agree with spanning the elbow and putting it in the ECRB, because in my experience, in such cases, it either flexes the elbow or extends the wrist. It does not work very well for ECRB.
I agree wholeheartedly to that. It is only that for the first thing is, I don't think the elbow flexion gets compromised. The ECRB gets compromised. That's what you imply, isn't it?
No, I feel that although your rotator cuff was working and your deltoid was working, and to a certain extent your pectoralis major, the gracilis is still spanning the elbow.
Okay.
Now, your proximal insertion is to a mobile muscle, to a mobile structure, that is the pectoralis major. You have not sutured it to the clavicle. So
no. Let me explain that. I usually cut a cuff of the muscle and I suture it both to that and take some bites through the clavicle also.
Yet you're asking the gracilis to stabilize your head of the humerus as well as flex the elbow, and you have put it on the ECR on a muscle which is going to be inserted beyond the wrist.
Okay.
There is no anchorage close to the elbow.
Okay.
So your leverage is from a loose point on proximally to a loose point distally.
Okay.
And because of the lack of focus, perhaps you might have to revise your distal repair later on in order to focus it on the elbow. Perhaps. We don't know how it will pan out. But of course, I would have given it a better now.
Okay. Now, I routinely do it to the spinal axillary nerve. No questions asked about that. But I have quite a few number of patients in which I have used the pectoral nerve also, provided I'm sure about the quality of stimulation that comes after I stimulate it. But in this particular case, I made sure that I did not take the entire pectoral nerve. There was
that is precisely my point. That since you have been tried to play God and cut only part of your donor nerve, how do you know that donor nerve contains live axons? It is stimulable for the entire pectoral nerve. It is not stimulable only for the fascicles that you had divided.
No, I don't mean that. What I mean is knowing that the lateral pectoral nerve is coming from the C5, C6. And knowing that the infraclavicular injury is distal to the origin of the lateral pectoral nerve, because the injury was far distal to that. So I am essentially meaning that pectoral nerve was normal.
But anyway,
I got it.
Let us see how it pans out.
Okay.
It's an idea, since considering that innervating the musculocutaneous nerve was not an option here.
Yeah.
You yourself said that you found it injured even between the heads of the biceps.
Yes.
So wasting a nerve procedure for the biceps would have been a relatively less fruitful exercise. So and in your hands, the gracilis is a no-brainer. So
can you repeat that LD to triceps once again for the benefit of the audience?
See, since the upper trunk continuity along the posterior division to the axillary nerve was already documented, and the axillary nerve was stimulable.
Yes.
That it contained live axons. The thoracodorsal nerve inevitably arises from that portion of the posterior cord, the portion of the posterior cord that goes to the axillary nerve. And so, if the thoracodorsal nerve also gave a good response on stimulation,
Yes.
I would be happy to sacrifice that in order to get a direct innervation of the radial branches to the triceps.
Okay. Okay.
Shall we move on, or
yes, I think so.
We move on.
Yes. Okay. Can we go to the next case?
No, that's it, isn't it? Or you are presenting a case?
Yes, I am presenting a case. That's it. I'll not take much time. Just to evoke interest in the birth-related brachial plexus injuries also, we have included one case where I can share the screen to all of you. And Nancy, can you hear me?
Yes, doctor.
So I'd like to, when you fill up the forms for the registration for the Cadaveric workshop, just make sure you have included the participants who
They can see the doctor.
Yeah, I know, who've been doing brachial plexus less than 5 years, more than 5 years, because we have to plan our program accordingly.
Sure, doctor.
Yeah, so you can see the screen. Okay. Are you all able to see the screen? No, just look at this child, all of you, birth-related 5-month-old baby, 3.5 kg at birth weight. Just observe the upper limb on the right side. I'll going to play the video again. There's no active abduction of the shoulder, no active axial notation. Elbow is extended. And also, if you see the wrist in the flexion attitude, there's only a flicker of fingers. There is no wrist extension. There is no finger or thumb extension. Now, if you all of you are aware about the classification, you have Naraka's classification. Group 1, you have classic upper trunk 5-6 lesion, where you have only the involvement of the weakness of shoulder abduction, axial notation, and weakness of elbow flexion. Group 2 is extended upper trunk lesion, where you have involvement of, in addition to the shoulder abduction, axial notation, and weakness of elbow flexion, you also have weakness of the elbow extension, finger and wrist extension, C7. So group 3 is a flail extremity, total flail extremity, no whatsoever, or you might have a small flicker of finger in the group 3 flail extremity. And in group 4, you have a flail extremity with a Horner's syndrome. Now, this patient in question would have fit in either in an extended upper trunk lesion 5 and 6, or it would be a completely flail extremity with only a flicker of finger movements. Now, MRI was able to see the avulsion of the 7 and C8 and some signal changes in the T1, whereas the 5 and 6 routes are available. Now, if you look at the timing of repair, 5, 6, 7 kind of a presentation. The recovery, I wait for the recovery of biceps and wrist extension by 4 months. By 4 to 6 months, we expect the biceps and the wrist extension to recover. In 3 and 4 Naraka, that's a totally flail upper limb, or in a patient with a flail upper limb with Horner's syndrome. So you just wait for the recovery of biceps, wrist and finger extension by 4 months, or based on the Toronto score, you make a decision on that. So when there is no hand function, it's inevitable that you consult the patient starting from the age of 2 months, 3 months, and you plan to explore and where primary reconstruction of the complete brachial plexus as early as 3 to 4 months in a total palsy. Whereas in C5, 6, 7, you look for recovery of biceps, wrist extension by 4 to 6 months. You have 2 months extra margin there to wait and see the recovery. If not, you go ahead and plan your exploration. Now, this child, because there was no recovery by 6 months, plan to explore. The strategy I usually follow is, whenever you have 3 routes available, take the best route to the lower trunk, take the next best route to the anterior region of upper trunk, the C7 to the posterior region or the middle trunk, and the spinal axis to suprascapular. So you're lucky if you're able to get 3 routes, because you can reconstruct the whole upper, middle, and lower trunk. But most of the time, you have only 2 routes available in a total palsy. So use the best route to the lower trunk, the next back to the upper trunk. the spinal axis to the suprascapular now. When you have only one route available, I use the C5 to the lower trunk, intercostal to musculocutaneous nerve for elbow flexion, and spinal axis to suprascapular for shoulder abduction and inclination. And whenever there is no route available in a children, this percentage of children with no route, because it's a low velocity injury, it's very, very unlikely that no routes available in this children, but there is a possibility. And then I use the contractile C7 to lower trunk, spinal axis to suprascapular, intercostal musculocutaneous. But the contractile C7 to the ipsilateral lower trunk is with a cable graft of say 4 to 5 centimeters. So sural cable graft of 4 to 5 centimeters. Spinal axis to suprascapular for shoulder function, and intercostal musculocutaneous for elbow flexion. So targeting all the three functions. Now this child in question, we had the C5, C6 ruptured, as you can see the scarring here, and then there was the C7 was avulsed, the C8 was avulsed, and then the T1 was intact. That's why you could see the flicker of finger flexion. I was able to stimulate it intraoperatively, and I could see the flicker of finger movements on intraop. So the plan was to do a C5 with a sural cable graft to anterior and posterior division of upper trunk and upper trunk. C6 with a direct root correction. If you can, as much as possible in children, I try and do a direct root transfer, ipsilateral direct root transfer to C8, because that gives a very good function of the hand. So I was able to mobilize the C8 to connect it to C6 to C8, proximal C6 to distal C8 connection. And then in addition to that, I also did a spinal axis to suprascapular now. So this is the spinal axis to suprascapular now. This is the proximal head end of the child, and this is the caudal side. And here you have the proximal C5. It's a good route with multiple cable grafts, 3 cables to the anterior division, 2 cables to the posterior division. And then you can see this is the C6 with the proximal C6 route, and this is the site of anastomosis. And this is C8. I was able to mobilize the C8 directly to C6 in order to give the hand function. Now, if you see the patterns of route transfer I follow usually is either you can, whichever route is good, C5, depending on which route you are able to mobilize directly, ipsilateral route. Sometimes you are able to mobilize C5 to C8 even directly, or then you use the C6 with the cable graft, or you can use the C5 with the cable graft or C6 to direct route, whichever good route is able to give hand function. That's a priority. That's called a direct route ipsilateral route transfer. As much as possible, trying at least one route for the low trunk, which can be directly anastomosed without any need for the nerve graft. Now, if you look at this representation of how we do it, this is division of the proximal route, the good route. Looking at the healthy vesicles in the C5 there, and here you can see the division of the lower trunk, the C8. As you can looking at the vesicles of the C8, red loafing of the C8, and then we're able to approximate the C8 to C5 directly, this child. And that's the 5 years post of video. We can just observe this child. Although there is a flexion attitude in the wrist, but he's able to do the wrist extension, finger extension, grasp objects, take it to the mouth. That's the shoulder abduction, externodation. And then the elbow, you get independent flexion and extension. And also is able to take hand to the mouth. So that's the kind of recovery you see in the 5 years post-op. So what point I wanted to make it clear that ipsilateral direct route transfer is possible in children, and that gives the better outcomes. Any questions on this? Am I audible? Hello?
Yes, excellent result, Bharat.
Thank you.
As we are all agreed, systematic exploration of the entire brachial plexus and utilizing the strategy that works in your hand should be the way forward. We should not innervation of the rotator cuff. I agree that we should do a nerve transfer. I am not keen on nerve grafting to the suprascapular nerve. So the abduction that you have achieved can be attributed to that. The nerve grafting from the from the C5 to the anterior and posterior divisions of the upper trunk did not seem to provide a deltoid in this case, but that is not a big hardship. The abduction when the patient becomes an adult would be about this much only. It would not from the rotator cuff. This is what one can expect. What is heartening is that you got good elbow flexion from the nerve graft in the neck, which the patient can harness independently.
Dr. Anil, can I ask something in continuation to what you said?
Sure.
Now, this is a small child. So essentially what he has done is he has transferred a single root to the C8 T1.
No, he has transferred it to the C8 and not to the T1.
Not to the T1.
The
T1 is
intrinsics
intact.
are functioning.
Yes.
What he has contributed is in fact the finger extension.
Okay.
Yes.
The triceps and the finger extension is what has come from the C6.
Yes.
This is the strange part, that the C6, which clinically never supplies the triceps. That means in the brain, the C6 is mapped for elbow flexion.
Yeah.
Here, since these growing axons, the child is able to harness for elbow extension. So this is a non-physiological nerve transfer, but seems to have worked well since it was a birth palsy.
Okay.
In a post-traumatic palsy in my hands, that hasn't worked. In a post-traumatic palsy, even if I were to do a direct repair of the lower trunk without separating out the posterior division of the lower trunk, the patient would be confused between finger flexion and finger extension, and the eventual grip is very weak, even when I do it in a 2-year-old child. So the in a birth palsy, maybe this sort of intraplexural nerve transfer seems to be successful.
Okay.
Thank you. We have done with the case discussions, and then I would like to take your inputs as to how we, any suggestions on how we have the cadaver workshop for all the participants to get to know. We want to start from the basics, depending on the profile of our participants, and then we would like to add on something for our. We have a 28 and 29 2 days workshop. On 29th, 28th we'll be having again case discussion, faculty talks, and then also from the international faculty on the recent advances in management of these brachial injuries. So any other suggestions, Dr. Bhatia, Dr. Srikanth, Dr. Purushottam, Dr. Piyush, on how to go about it? A couple of lines, and then we should be able to wind up the session.
The dissection is only for day 2.
Exactly, whole day, 8 to 5.
So how many participants you're going to have?
So max of 45. We have 15 limbs exactly.
15 limbs.
15 limbs, 2 to 3 on each side.
Okay.
Yeah.
You envisage that there's going to be one faculty who is going to demonstrate, which is going.
We'll allot one procedure for one faculty. So we have a separate cadaver for a demo for the faculty.
Okay.
So, for example, you do one procedure, supraclavicular exposure, starting from the basics, infraclavicular exposure, and then we have the nerve transfer, spinal axis, suprascapular, intercostal musculateneous.
Right.
And that way we'll show one by one procedure, and then the Wang's procedure.
Okay.
Is it okay, Dr. Bhatia?
Any
suggestions?
Regarding the lecture session, maybe we can decide the program closer to the dates after we know the profiles of the people who have registered.
Got it.
Because we don't. If somebody is already doing some amount of brachial plexus surgery in his or her clinical practice,
yes,
it would be futile to talk about the anatomy and all that. We can skip those basic sessions and highlight clinical practice in terms of clinical examination, the steps in dissection, because as we have all realized, in a cadaveric course, we can only convincingly demonstrate nerve transfers. We can't explain the nitty-gritty of surgical dissection of the scarred brachial plexus in a cadaver. So that would be the prominent. I would lay a lot of emphasis on that during the discussion day, and devote the cadaveric portion for exposure of the donor and recipient nerves for each procedure.
Thank you, Dr. Bhatia. I think the request to all the participants is there are limited seats available. You can register early. You can have a great learning experience. Looking forward to see you all. Anything from Dr. Purushottam, sir? Yeah, that's. And see,
Doctor? Yes, doctor.
we were done with the case discussions for today.
Okay, doctor.
And then I will keep updating you. I think we can wind up the sessions.
Sure, doctor. Sure.
And chat box, I don't see any more questions right now.
Yeah, doctor, I have shared you the queries.
Yes, we have answered them, most of them.
Okay, fine.
Yes.
So I'll just conclude it. The session is completed, and we have so thank you all for joining the webinar, and we hope that you have learned a lot of things. So for any further questions, you can feel reach to us. And thank you all and have a nice day. For the brochure, we will just share you the PPT just now. Let's just show the brochure. Yeah. So this is a brochure. So if anyone would like to register and want to know more about the brachial plexus cadaver workshop, can directly join for the cadaver workshop, and you can directly contact our sales team. This is our show the number.
Thank you very much. Bye.
Thank you, everyone.
Thank you.
Dr. Bharat, thanks.
Yes, sir. Thank you, sir. Thank you so much. Most welcome. Looking forward to see you all on 28th.
Yeah.
Thank you so much. 28th of October.
Thank you, doctor.
Thank you.